Welcome, everyone, to Evidence-Based Cardiology Talks.
It's great to be here.
You know, as cardiologists, we're always juggling patient care with trying to keep up with the latest research. It's a lot.
Absolutely, there's always something new coming out.
So that's what we're here for. We're your hosts, and in these deep dives, we try to unpack the really crucial new publications in cardiology today.
Kind of a shortcut to the key evidence.
Exactly. And just a reminder, we do all this under the supervision of Dr. Caroli. You can find his work at ddarcaroli.com.
Right. So today we're tackling a big one, especially for anyone dealing with complex coronary artery disease.
Ah, yes. The PCI versus CABG debate. It never really goes away, does it?
Not entirely. And today we're zeroing in on the 5-year follow-up data from the FAME-3 trial. This really hits that core question for multivessel disease.
Okay, FAME-3. So just to set the scene, we're talking multivessel CAD, but not involving the left main, correct?
Precisely. That's the specific population FAME-3 looked at. And, historically, CMBG often seem to have the edge in the long run for these
It's on older trials, yeah. But techniques, stents, medical therapy, everything's evolved quite a bit.
Immensely. So FAME-3 was designed to give us, well, a more contemporary look. It compared FFR-guided PCI using current-gen zodorolimus-eluting stents against CABG.
FFR-guided PCI, that's key. And we've seen some earlier results from FAME-3 already. The one-year data, if I remember right, PCI didn't quite hit non-inferiority for the main composite endpoint.
That's right. The initial one-year MCCE endpoint death, MI, stroke, or repeat revascularization PCI didn't meet the non-inferiority mark.
But then the 3-year results came out.
Yes, and at 3 years, focusing on just death, stroke, or MI, the sort of harder endpoints, there wasn't a significant difference between the two strategies.
Okay, so that leads us to now. This latest paper is the final pre-planned 5-year look.
Exactly. The full 5-year follow-up, specifically looking at that composite of death, stroke, or myocardial infarction. It's the long-game perspective.
The data everyone's been waiting for, really. So let's get into it. What are the headline numbers?
Okay, so they enrolled 1,500 patients. It was split pretty evenly, about 750 in each arm, PCI and CABG.
And this was across, what, 48 centers?
Yeah, 48 sites, Europe, US, Canada, Australia, Asia.
Oh.
Quite a global effort. And importantly, follow-up was really good.
How good?
Over 95% in the PCI group, around 94% for CABG at 5 years. So, we can be pretty confident in the data capture.
That's excellent. Really robust. Okay, so the main event. 5 years, the composite of death, stroke, or MI. What did it show?
The bottom line. No statistically significant difference. It was 16% in the PCI group versus 14% in the CABG.
16 versus 14%?
Right. The hazard ratio was 1.16, and the p-value was 0.27. So based on this primary endpoint for the 5-year analysis, PCI wasn't significantly worse or better than CABG.
Okay. Wow, that's a pretty major finding compared to maybe what we expected based on older data.
It is. But we need to unpack the components, too.
Definitely. Let's break down that composite. What about all-cause mortality?
The death rates were almost identical, 7% in both groups. Hazard ratio 0.99, so absolutely no difference there.
Okay.
And stroke?
Stroke rates were also not significantly different. Numerically a bit lower with PCI, actually 2% versus 3%, but the p-value didn't reach significance. Hazard ratio 0.65.
So death and stroke are looking very similar. What about MI, myocardial infarction?
Ah, no, that's where we see a difference. The MI rate was significantly higher in the PCI group.
Higher with PCI. How much higher?
It was 8% in the PCI arm compared to 5% in the CABG arm. And that difference was statistically significant, p less than 0.05. Hazard ratio 1.57.
8% versus 5%. Okay, that's notable. And the other big one people always discuss, repeat procedures.
Yeah, repeat revascularization. Also significantly higher with PCI. As many might expect, it was 16% needing another procedure in the PCI group versus only 8% in the CABG group.
Double the rate. Pretty much. Hazard ratio 2.02, highly significant. And if you look at a broader composite endpoint, one that includes repeat revascularization along with death, stroke, and MI.
Then CABG comes out ahead.
Yes. Then CABG showed better outcomes. That composite event rate was 18% for CABG versus 25% for PCI. Hazard ratio 1.44.
Okay, so summarizing that, For the pre-specified 5-year look at death, stroke, or MI, no significant difference. But PCI patients had more MIs and definitely needed more repeat procedures down the line.
That's the gist of it, yes.
How does this stack up against those older landmark trials? You mentioned Syntax, Freedom.
Right. Well, those trials, using older PCI tech and maybe less consistent medical therapy, generally showed a clearer, more significant benefit for CABG across the board, including for death and MI at 5 years.
And FAME3 is different.
Yes. What's really striking in FAME3 is, first, the absolute event rates are lower in both arms compared to those older studies. And second, the difference between PCI and CABG for these hard endpoints is much narrower, and it didn't seem to widen between year 1 and year 5.
Interesting. So the gap has closed. You mentioned the BEST trial, too.
Yeah, Best also hinted at this trend, suggesting that with more modern PCI techniques, the outcomes might be converging somewhat with CABG. FAME3 really reinforces that idea with robust FFR-guided data.
So what's driving this convergence? Why are the FAME3 results looking, well, more balanced than Syntax, for example?
It's likely multifactorial. One big thing is probably the background medical therapy.
Guideline-directed medical therapy, you mean?
Exactly. It was really emphasized in FAME3 for both groups. Better statins, better antiplatelets, better BP control. That likely improved outcomes for everyone, perhaps narrowing the gap that revascularization strategy alone could make.
Makes sense. Optimal medical therapy is the foundation. What else? Improvements in the procedures themselves.
For sure. On the CAG side, surgical techniques have improved, reducing upfront mortality risk, although interestingly, post-op AFib was still pretty common in FAME3.
And AFib carries its own risks later on.
It does. And CABG in FAME3 also had higher rates of bleeding complications, which we know impacts outcomes negatively.
Okay. And the PCI side, big changes there over the years.
Huge changes. FAME3 saw high use of radial access, around 70%, which cuts down bleeding compared to femoral.
Definitely.
Then there's the stents, current generation drug-eluting stents, much better safety and efficacy long-term compared to first-gen DES or bare metal stents used in older trials.
And the FSR guidance, that must be critical too.
Absolutely critical. Using FFR to only stent lesions that are physiologically significant, causing ischemia, means you're likely treating the lesions that matter most and perhaps avoiding unnecessary stenting elsewhere. It's a more targeted approach.
So it's this combination, better meds for everyone, plus refinements in surgery, plus really significant advances in PCI with FFR and modern stents.
That seems to be the most plausible explanation for why FAME3 shows these more comparable results for the hardest endpoints, yeah.
Did they look at subgroups? Did these results hold up across different types of patients?
They did run pre-specified subgroup analyses. And mostly, the main finding held true across different groups, age, diabetes, status, etc.
Mostly. Any exceptions?
The main one that showed an interaction was the Syntax score.
Ah, disease complexity. What did they find there?
Basically, for patients with lower complexity disease, a Syntax score of 22 or less PCI outcomes looked very similar to KG outcomes overall.
Okay.
But in patients with higher complexity disease, Syntax score above 22, the outcomes with PCI tended to be worse compared to KG.
So complexity still matters. That Syntax score interaction reinforces that. Perhaps PCI is a very reasonable option for less complex 3-vessel disease, but CABG might still hold an advantage for the really complex cases.
That's certainly one interpretation, and it lines up with a lot of clinical intuition, I think. It highlights that patient selection and anatomical assessment remain key.
Absolutely. Now, we always have to talk limitations. No study is perfect. What are the key caveats for FAME3's 5-year results?
Good point. First, remember, the primary endpoint of the original FAME3 trial was at 1 year. This 5-year analysis of death, stroke, MI was a pre-specified secondary endpoint, but the trial wasn't formally powered for it.
So the lack of a statistically significant difference needs that caveat it might be underpowered to detect a true smaller difference.
Precisely. Also, 5 years is good, but maybe not long enough. Differences, particularly with graft failure versus stent issues, might emerge later.
True. Longer follow-up is always informative. What else?
Well, the endpoint itself, this 5-year composite didn't include repeat revascularization.
Which we saw was significantly higher with PCI.
Right. And while it's not a hard endpoint like death, repeat procedures matter to patients and the healthcare system, and some data links them to bleed mortality too.
Other outcomes not captured in that main composite.
Yeah, things like post-op AFib, bleeding, rehospitalization rates, which were generally higher acutely with CABG, aren't factored into that primary 5-year outcome measure. Also, on the CABG side, the use of multiple arterial grafts, like bilateral IMAs, was fairly low, only about 25%. Some would argue optimal CABG involves more arterial grafting.
And PCI techniques could potentially be optimized further too.
Potentially. Intravascular imaging like IVUS or OCT was only used in about 12% of PCI cases. There's growing evidence that imaging guidance can improve PCI outcomes, so maybe routine use could have narrowed the gap even further, or maybe not. We don't know from this trial.
And patient demographics.
Limited representation of women and certain minority ethnic groups, which is a common issue in many cardiology trials, unfortunately.
Okay, so several important points to keep in mind when we're applying these results, but despite the limitations, what's the big picture clinical message here?
I think the main takeaway is that FAME3 gives us really solid contemporary evidence that for many patients with three-vessel disease without left and main involvement, the gap in major heart outcomes between modern FFR-guided PCI and CABG at 5 years is much smaller than we thought based on older studies.
It really levels the playing field, in a sense, for those key endpoints.
It does. And that empowers us to have better, more nuanced, shared decision-making conversations with our patients. It's not necessarily an automatic CABG recommendation anymore for all three-vessel disease.
Right. So let's quickly recap the core findings from this FAME3 5-year deep dive.
Okay.
In patients with three-vessel CAD, no left main, FFR-guided PCI with current DES showed no significant difference compared to CABG at 5 years for the composite of death, stroke, or MI.
Correct.
However, digging deeper, PCI did lead to a significantly higher rate of myocardial infarction during follow-up.
Yes, 8% fast failure percent.
And also a much higher rate of needing repeat revascularization procedures.
16% versus 8%, also significant.
So it paints a picture where the most severe outcomes are similar, but the journey after PCI might involve more bumps in the road, specifically MIs and repeat procedures.
That's a fair summary. And it really highlights why we need to individualize treatment, considering the patient's anatomy via things like Sontag score, their procedural risks, their preferences regarding repeat procedures versus upfront surgery. It's a complex discussion.
But it absolutely is. This has been incredibly helpful, really clarifying these important long-term findings.
Glad we could dive into it.
And for everyone listening, if you found this useful for your practice, please do subscribe to Evidence-Based Cardiology Talks. We're on Spotify, YouTube, wherever you get your podcasts. We'll keep bringing you these deep dives into the evidence that matters.
Definitely subscribe. And maybe leave you with a thought. We see this evolving landscape, these narrowing differences in heart outcomes in FAME3. How does this concrete 5-year data actually change your conversations and your threshold when discussing PCI versus CABG with suitable patients day to day? Something to reflect on.
A perfect question to end on. Thanks again for joining us on Evidence-Based Cardiology Talks. We'll catch you on the next deep dive.